In my speech on the motion on supporting healthcare in May last year, I spoke about how hospital bed and medical personnel capacity in our fair nation falls short of what may be expected, not just compared to almost every other advanced economy, but also to our own internal benchmarks. This has led to us failing to meet health service quality targets set by the Ministry of Health. Things have improved somewhat since then, but capacity still remains constrained. Median wait times at the end of January can still exceed half a day in Changi General and Khoo Teck Puat, while the bed occupancy rate for all but one of the public hospitals hovers above the ministry's own preferred 80% ceiling. There is a dire need to relieve not only our capacity shortfalls in the short run, but also any projected long-run need. Indeed, the planned expansion of Alexandra Hospital and the Woodlands Health Campus is likely to only fix current shortfalls, but remain insufficient as our population grows and ages. What this comes down to is a willingness to sacrifice short-run efficiency by accepting a certain amount of redundancy in the interim, at least until the needs inevitably arise. My sense is that this will only occur when our current occupancy rate for hospitals remains substantially below 80%, at least for a certain duration. To achieve this, I believe that the current system can stand to expand its transition care offerings. I will suggest 3 ideas. First, we can ramp up our urgent care offerings as an intermediate option, complementing existing GP polyclinics versus A&E solutions. While still uncommon, there are already several urgent care centers or UCCs in Singapore, including the reclassification of Alexandra Hospital's A&E department into a UCC, along with several private providers. Singaporeans should be educated about using this channel for non-life-threatening medical emergencies, especially with regard to the substantially shorter wait times compared to A&E. It can also relieve the pressure on polyclinics to triage such cases for which they are not designed for. Second, we can improve the incentives for transition care at home, perhaps with cash incentives paid directly to patients using savings that would otherwise go toward hospitalization expenses. The government can directly encourage this by providing rebates to insurance companies for encouraging select cases to pursue this route. Third, while I support the decision to expand the non-profit model, whether the experiment will ultimately prove viable will also hinge, crucially, on whether the associated tax exemptions are accompanied by increased or decreased flexibility of operations. Otherwise, if the approach is simply one of delivering more subsidies in exchange for greater health price regulation, economy plus healthcare, the true advantage of the non-profit model may be lost. At the same time, I encourage MOE to also look at public health bills.